Okay, well, why don't we get started? I want to thank everyone for joining the webinar today. I think the first two sessions were incredibly interesting. We're going to have two very prominent speakers here for our third session. And the topic of our session today is COVID vaccines. Is there a need for boosters in view of the emergence of variants and waning immunity? I'll be your host. I'm Dr. Anna Durbin. I'm Director of the Center for Immunization Research at the Johns Hopkins Bloomberg School of Public Health and a member of the ADVAC Scientific Committee. And it's really my pleasure to have two very eminent speakers with us today, Dr. Jakob Cramer, who's with the Coalition of Epidemic Preparedness and Innovations, or CEPI. And the title of his talk will be Booster versus 2+1 Primary Immunization Vaccine, Does It Matter? And then the second speaker, who really needs no introduction in the vaccine world, is Dr. Stanley Plotkin from the University of Pennsylvania. And he will be discussing correlates of protection as indicators for third doses of COVID vaccines. I want to remind everyone to put your questions into the chat. I will be monitoring the chat at the end of the sessions, and we can then ask the speakers directly the questions that you've put in the chat. I think what I would like to do is have both speakers get through their talks, and then we'll start to address questions to make sure that we have plenty of time for both talks and for all speakers. So I think without further ado, I'm going to turn it over to Dr. Cramer. Thank you very much.
Thank you, Anna, very much for the kind introduction. I also want to thank the organizers for inviting me here to present today. So let me share my screen quickly, and while I'm doing this, I'd like to state right away and upfront that this is a difficult topic. It is a political and an immunologic vaccine clinical efficacy discussion. And we do not know everything yet, both for some of the new vaccine platform technologies, but certainly also around corona vaccines, which we have never been using in human mankind. So there's a lot of questions that can only be answered as time passes by. But let me start today with a statement here from Dr. Tedros, which you probably all know. A few weeks ago, he had called for a moratorium not to booster until the end of September. And very recently, he has said another statement on top of that, as the situation hasn't changed yet with regards to vaccine supply. So today I'm calling for an extension of the moratorium until at least the end of the year to enable every country to vaccinate at least 40% of its population. That's what he said. So you can see the question isn't that easy. And it's difficult to answer it, solely based on should it be done, can it be done, is there an advantage based on immunogenicity and potentially vaccine effectiveness. To summarize just three, there's a lot of discussions that we have in CEPI around booster doses at the moment as well. And obviously you always focus on should it be done, what are the advantages? And these are three major aspects. Being here on a discussion with Stanley today, I'm sure this list is incomplete, but just to set the scene a little bit and to help with my slide deck, I wanted to summarize these three aspects for booster vaccination. So one is certainly to improve the immune response. What we usually do is we measure antibody titers, and that is something we can look at. We can see the figures, whether the antibodies go up after prime immunization. Do they stay up there? Do they decline over time? And what is the how quickly do they actually decline then after immune response? What does this mean? What is a protective level of antibodies? And I'm sure that Stanley will go into further details on this question. But it's not just about antibody titers and trying to maintain them at high levels. It's also about antibody maturation and other things that we need to keep in mind. And obviously, it's not only antibodies that are protecting against disease necessarily. We'd like to prolong the immune response. Sometimes primary immunization will provide a good immune response. We in CEPI, we discuss single dose strategies in particular, since we are an epidemic preparedness innovations organization, so we would like to react quickly to outbreaks. So it's important to mount an immune response rather quickly, like it was at the beginning of this pandemic. But as it moves into a post-pandemic phase now, I guess public health authorities turn their heads towards the duration of the immune response, protective immune response, and what it could mean moving forward. No one wants to booster every 6 months to maintain protective levels. And finally, since we do not have vaccines at the moment that are adapted to new SARS-CoV-2 variants, and I think we all agree at the moment we are okay, certainly in terms of protecting against severe disease and hospitalization. The question is, can we maybe booster our way out of the variants? The original SARS-CoV-2 strain has more or less completely disappeared. We're only facing variants at the moment. We see this from ongoing phase 3 vaccine efficacy trials, for example. Can we boost our way out of this? So can we broaden the immune response, increase the cross-neutralization with an additional third dose in this context? But the world is, I guess, getting more complex. It was quite nice, I have to say, when I remember back in November 2020, when we saw first vaccine efficacy trials reading out, they had a perfect match between the vaccine-contained strains and the circulating strains. And I think we all fell off the chairs a little bit when we saw these very high point estimates against the respiratory disease and the vaccine-mediated vaccine efficacy, clinical efficacy. Moving forward, things become more complicated. We still have the original variant included in the vaccine, but we no longer have the original variant virus out there. So what is our primary public health objective? Is it to have an effect on the pandemic itself, on epidemiology, block transmission by preventing infections, maybe even as the kind of highest or most difficult vaccine preventable endpoint? Or is it just to prevent mortality and morbidity, really to prevent severe disease, hospitalization, death? I think these are, and you will see that this kind of is kind of a red line through my entire presentation to separate between these two public health objectives, because it's also different concepts in terms of protective immunity and vaccine effects. And then also in the context of, do we need to booster? I mentioned already variant of concerns. Another aspect that has to be kept in mind and has to be looked at is more an operational aspect, first of all. We are probably able to boost individuals and populations with the same vaccine given 3 weeks apart. It's at least in many areas not so difficult to have that same vaccine around for a while. But if it comes to providing an additional dose months later, 6 months later, maybe even a year later, will these regions still have the same vaccine in stock? Or is there even safety signals popping up affecting age recommendations, as we have seen, for example, for the AstraZeneca vaccine? So are we are maybe forced to consider heterologous vaccination regimen, or simply from an operational perspective, we have no choice in doing this? So the first question was, can we do this? Can we use them in an interchangeable manner? And then the second question would be, should we even use different vaccines for booster vaccination, for example, as they all, they all different in terms of the antigen, potentially full lengths or receptor binding domain, in terms of the platform and the type of immune response they elicit. And there is a lot of discussion and a lot of data now that is accruing whether or not certain heterologous regimen are even better than homologous vaccinations. Which vaccine should be used or prioritized for booster doses? Should it be the vaccine with the highest immunogenicity, or the vaccine that makes most sense in a heterologous priming or heterologous boosting regimen? Should we look at neutralizing antibodies versus CMI? Is there maybe an age-specific objective? And then again, to mention my first two bullet points, what do we focus on? Blocking transmission or preventing disease? Or should we simply use the vaccine most widely available? Be completely pragmatic, let's boost with whatever vaccine we have, but we do need data demonstrating that vaccines can be used interchangeably. And then the discussion, which is certainly related to the initial comment showed by Dr. Tedros, should we really provide a booster vaccination to all that have been primed, or selected populations at risk for severe disease or infection? So immunocompromised patients, older age groups, chronic diseases, or only for specific weakly immunogenic vaccines, for example, that have shown rapidly declining antibody titers and also increasing breakthrough cases over time. And should we maybe prioritize healthcare workers which are at risk for infection? There's, I think, 15 countries now out there that have released recommendations for booster vaccinations, most of them in selected populations, including older age groups. Only a few of them have elicited booster recommendations to general populations so far. So booster versus additional doses, this is what I selected a little bit as the title of my presentation, because whether or not you vaccinate for priming and then you give 2 doses for priming or 3 doses for priming, or is the 3rd dose already a first booster dose, or even if the first dose is given for priming, first priming and the second booster dose given for priming, is in the end terminology that we try to define from a regulatory perspective, labeling perspective, and so on. The immune system may not necessarily care whether or not we call it primary immunization or booster vaccination. However, from a political point of view, as you can imagine, booster vaccination triggers a lot of discussion at the moment. So let me not address too much the general need for booster vaccination in the general population, but maybe refer to an additional dose, an additional 3rd dose, if the primary immunization has been done based on 2 doses, for specific populations that may certainly need an additional 3rd dose or 2nd dose, if it was a single dose primary immunization, to mount a protective immune response, broad immune response, and to maintain the immune response over time. So additional doses in the sense of a 2+1 regimen may be required in case there is a rapid initial decline in antibody levels with some of the less immunogenic vaccines, as mentioned, and also potentially in special populations. Think of hepatitis B vaccine, for example, which has a schedule similar to the one we are discussing now for COVID-19 vaccines, 2 doses given 4 weeks apart, and then the 3rd dose to be given 6 months to 12 months after the first 2 doses, and that is considered as a primary immunization regimen. In that context, the first question I'd like to address is, should we boost? Is there a problem out there? And we do see a lot of real-world data coming up, and there's a lot of controversy. These real-world data have deficits and challenges in terms of design feature and so on, which is clear. These are real-world data with caveats, obviously. These are not prospectively planned, controlled clinical trials. But let us have a look at the data that we have been seeing or are seeing from Israel. And what I'm showing you here with this figure is data from the public health records in Israel. And you can see 3 different figures here stratified by age, 16 through 39, 14 through 59, and then 60 plus. And what you see is the time that has passed since these individuals within these age groups had received their primary immunization. So the dark color here is the longer period of time. So Israel started to boost in July this year. And in the dark gray, you see that those individuals that had received their priming in January. And then it goes down to May. And what you can see is the incidence per 1,000 persons of SARS-CoV-2 infections, so PCR-confirmed infections. And you can see the longer the priming has passed by, the higher the incidence actually is for infection. That, as you can see here, holds true, at least according to these real-world data out of Israel, for younger age groups as well. These white bars are younger age groups that work as healthcare workers. At that time, there was no recommendation. So at that time, meaning April, May, there was no, sorry, beginning of the year, there was no formal recommendation to vaccinate under these certain age groups, in these certain age groups, apart from healthcare workers. That's why these bars are a little bit marked differently. So this is the data for SARS-CoV-2 infection, indicating that you lose, or the vaccine efficacy against infection declines over time. That could be due to decreasing protective immune responses, or obviously could be due to circulating variants. And this obviously coincides with the Delta variant, I would say. Let's have a look at the same figure, same data from Israel, similar picture, but this time it's for severe COVID-19 disease. And again, you see the age stratification, and you do see a difference between the older age groups and the younger age groups. So I would assume that in all age groups, you do see a circulation of the same variants, but there seems to be a difference in terms of vaccine efficacy if you stratify or if you analyze for severe disease. Now, are vaccines boosterable? Is the solution to, if this is a problem, if this is a true problem, and I know there's other real world data from other countries coming out now as well, but let's assume, and this is for the mRNA vaccine, the Pfizer-BioNTech vaccine that has been rolled out in Israel, is booster vaccinations, is that a solution? What I'm showing you here is data from the Mrna booster trial, where they have given 6 months after priming, either a half dose of mRNA of the Mrna vaccine containing the original variant, or a half dose, 50 microgram dose of the South African, apologies for the incorrect term, but 3.351 variant that had been first described in South Africa. And what you can see is this is the titers. The yellow bars are the titers before the third dose had been given, and then in blue you see the titers post third dose. And you can see stratified for different variants here that the immune response, although it had been declining quite significantly over time, over the 6 months, you've probably seen the data from Mrna as well, that there is a decrease in antibody titers. If you do boost, even with the half dose, then you do see a very good immune response. Now, 50 micrograms is still quite a high dose. The original dose is 100 micrograms. The Pfizer-BioNTech vaccine only has 30 micrograms included. So let's look at booster data from the Pfizer-BioNTech mRNA vaccine. Again, a third dose, full dose, 30 micrograms given 6 months after priming. And what you can see here is stratified by age groups, 18 through 55 and 65 through 85, that they also see a significant increase in titers post primary immunization compared to post third dose given for booster. And that holds true both for the original variant as well as the Delta variant here shown in blue. So vaccines are boosterable, and similar data have been shown for the whole variant inactivated vaccines, which also show a rapid decline in antibody titers over time. But if you boost with the third dose of Sinovac, for example, you do see a titer increase as well. So the SARS-CoV-2 vaccines seem to be boosterable. Now, does this translate into clinical relevance? Does this translate into public health benefit? And again, let's stay in Israel, there is data that had been published a few days ago. Again, there's a lot of debate around these real world data, and I acknowledge that. But what this group has shown here is that, again, on July 30th, Israel approved the Pfizer-BioNTech vaccine to be used as a booster vaccination in 60 and above, primed with the same vaccine 6 months earlier. And again, this is data from the Ministry of Health database, quite a high number of subjects that were analyzed. And they looked at those that had received a third dose given for booster on the day where this was approved through end of August. And they followed these individuals up for that month of August. Within that month, you can see that both, again, my initial public health objective, what I showed on the first slide, infection versus severe illness, for both, you can see that the outcomes, the confirmed cases of infection as well as severe illness cases are significantly lower in the booster, post-booster, as compared to those that had not received a booster dose from these real-world data. This is a different way to look at the same data. Again, that's the same study. This is data that had been shared recently with the FDA WebPAC meeting. What you can see here is, again, so that was July 30th, and then day by day, they kind of assessed the fold reduction in rate compared, so after 3 doses compared to 2 doses in terms of infection, again. And you can see that, again, if time passes by, there is after or a few days post 3rd dose, the protective effect is rather small. So this is probably also indicating the protective effect maybe if you had not received a booster dose here in the higher age group, but it does increase a few days after that 3rd dose. And that holds true for across age groups. Now, I'd like to address a few additional challenges related to additional doses or booster doses, whatever you want to call them. I already mentioned the mix and match aspects. I already mentioned that it was at first something that had been concerned from a, can we do this from an operational, from feasibility aspect, as it could not be guaranteed that the same vaccine that someone had received for primary immunization would also be available for booster. But as said, it's also interesting to learn whether or not combining different platform technologies may even provide a benefit in terms of, broadening the immune response, or even, addressing different branches of the immune response, including cellular immune response mechanism and so on. There might be a few additional considerations around adjuvant antigen saving strategies. Some of the vaccine production capacities are, connected to the availability of adjuvants, for example, and this, would allow, this flexibility would allow, obviously, to use vaccines or recommend rollout vaccines rather independent of vaccine supplies, manufacturing, export issues or limitations, and adjuvant availability. Is there maybe even an advantage if you had received 2 doses of a viral vector vaccine? Is there anti-vector immunity, which you can overcome with providing a different vaccine as an additional dose? Can we even have a beneficial effect on tolerability? You know that the 2nd dose, Mrna 2nd dose, other vaccine 2nd dose have shown higher reactogenicity as compared to 1st dose. We don't know yet if that is, if you see an even higher rate of reactogenicity post 3rd dose, or some of the safety signals that had been seen after some of the vaccines. So let's see. And there is data coming up for heterologous priming, but there's also data that will come up for heterologous boosting. They're not yet published, at least not from the UK task force supporting these trials. So I'm showing you data from the common cough study. This is a heterologous priming study, but there is a similar study that is currently being conducted in the UK on booster studies, which are somewhat in line with these data. And what you can see here in the left upper hand figure here is different regimen based on the AstraZeneca and the Pfizer-BioNTech vaccine. So the yellow line here is the the binding antibodies, IgG binding antibody titers post 2 doses of the AstraZeneca vaccine. And just giving any dose of that mRNA vaccine into the regimen, be it 1st, 2nd, or 2 doses of BioNTech, shows a much higher antibody titers. It's a logarithmic scale, shows a much higher binding antibody titer as compared to 2 doses of the viral vector vaccine from AstraZeneca. But if you look at the lower right-hand figure here, it's quite interesting, I think, to see that the best combination in terms of cellular immune response, and I know there is no such thing as cellular, it's based on different readouts, and it's difficult to assess cellular immune response, but let's assume that this is something indicating a benefit with regards to cellular immune response, you see that the efficacy, or not the efficacy, but the immune response based on cellular immune response is different as compared to the humoral immune response. The best regimen now is to start with an AstraZeneca vaccine and give a second dose of Pfizer-BioNTech as compared to all the other regimen. It's unclear yet how this holds true or will show post-boost. The interval is also relevant. A prolonged interval may be beneficial for antibody maturation, for example, or even increasing antibody titers, but the interval may also be relevant for cellular immune responses, and we will see further data coming up from those trials. What about fractional doses? If these subjects are already primed, do I have to give a full dose again? If you look at some of the phase 1 studies, which have done dose response or have generated dose response curves, you see that the majority of vaccines are actually based on the highest dose now that we are using out there. Moderna, 100 microgram, for example. There seems to be room for reduced doses. Maybe some of the reactogenicity and maybe even side effects are linked to the antigen concentration, and there could be a beneficial effect if the vaccine concentrations are reduced. However, would you simply go for half-dose vaccine without having any supportive or without redoing dose response curves for booster vaccinations? Pfizer, as you may have seen, is looking into a 10 microgram formulation in adolescents and even a 3 microgram formulation in infants now. So if there is a new formulation, it's quite difficult with the Pfizer formulation to actually take out half a dose. The full dose is only 0.3 milliliter. So how can you actually pull up with normal syringes, normal needles, half a dose of 0.15 milliliters? And if they are testing a 10 microgram vaccine in children now, which is a third of the full dose, should we not test a third, for example, as a fractional dose for booster vaccinations if a respective formulation for the Pfizer vaccine may come up in future? It's even more difficult for the viral vector vaccines, as the release specifications allow quite a wide variability of viral vectors included in the vaccine. So just giving half the volume could still be within the release spectrum, and which makes it even more difficult to move forward, just with half the volume, for example. Now, CEPI is trying to, or will look into this. We have organized a platform trial approach where we would like to test full versus fractional COVID-19 vaccines given as a single additional dose in selected prime population. And you can already see here that I'm trying to avoid the term booster. It's really for selected primed populations that do need an additional dose to maintain or complete to maintain the immune response, or to actually complete the primary immunization schedule. So we are defining some core elements. It's a single dose, full versus fractional. We also define the interval between that single dose and the assessment of the immune response. We'd like to see the immune response being assessed on binding antibodies, not neutralizing antibodies, simply because of capacity reasons, and they do correlate with each other. And based on these core elements, which we'd like to see to allow for some comparisons later on across individual trials, we do allow a lot of individual aspects, which I will show in the next slide. What we'd like to see is if fractional dose given as an additional dose, is this a suitable option to improve the immune response in these selected populations without impacting vaccine supply? And maybe is there even a chance to show an improved reactogenicity profile if that is necessary? So I'd like to generate data that maybe support pragmatic NITAC recommendations rather than label claims, and already mentioned the overall design. We'd like to see single versus fractional dose, 4-week interval before the next blood draw, and the flexible elements will come from the population that individual trials include in this trial. So it could be immunocompromised, solid organ transplant patients, HIV positive patients, elderly, immunosenescence. We would also like to see single fractional with full dose given to primed to populations primed by natural infection, which I will come back later. Will also be interesting to see in a third dose, full versus fractional, given after priming with weekly immunogenic vaccines, for example, the whole variant inactivated vaccines, which show rapid declining antibody titers. But as we have seen, maybe even the mRNA vaccines require a third dose, certainly in some selected populations. So in boxed in red are the core elements, full versus fractional, interval, and so on. And for the follow-up, we would like to see at least 3 months safety follow-up. Could be longer. We're actually encouraging to consider an additional blood draw 6 months later, because booster vaccinations, as I said initially, are important to assess the duration of the immune response, in addition to obviously other advantages. But let me end with this slide here. And I'm sure you have seen these types of slides. What you can see is in dark green, the proportion of the population in selected countries that have received full vaccination, and then light green is the proportion of populations that have at least, that have only partially been vaccinated, so first dose. The point I'd like to make is that, this high-income countries, among which you see Israel here, which I mentioned, there's very high vaccination coverage, up to 70%. And then there's countries here, mainly in Africa, which still have vaccination coverage below 5%. That is known to you. The point I'd like to make is, we in CEPI, we are supporting a lot of vaccine trials in different countries. And individuals presenting to vaccine trials are tested at baseline for seropositivity. And I do not have data, covering the global situation. But what we do see in different trials in different countries, in low and middle income countries, in those subjects presenting, obviously unvaccinated, to participate in a vaccine trial, are very high seropositivity rates of 50% in some countries. In one trial, we have seen 84% seropositivity in unvaccinated populations. From the same trials, we know that in high-income countries, Belgium, for example, 14% of seropositivity. These data are already 2 months old or 3 months old. But the point I'd like to make is that the world is moving into a more and more seropositive status. And do we still need to prime with 2 full doses of what has been tested a year ago in primarily immune-naive populations? Or is there room for fractional dose? Is there room for reduced numbers of doses, maybe prolonged intervals, and so on, which also is important in the context of booster vaccinations. So to conclude, the world needs more vaccine. We need more vaccines. We may need vaccines that will help us to booster. There is a shift from vaccinating immune-naive into vaccinating prime populations. There is more and more SARS-CoV-2 variants, which is very important in the context of the discussion around booster vaccinations. I would say that the immune response is decreasing. We still see very high vaccine effectiveness against severe disease, hospitalization, and death, which is really a good and reassuring a sign, even with the new variants. We still need more data to understand what declining antibody titers mean moving forward over time. I think the first mRNA vaccines have been given 9 months ago, or 10 months ago. That's the time that we oversee so far. Vaccines, the good news is vaccines are boosterable, and first data tell us that boosted immune responses have also, or translate into a benefit in terms of vaccine effectiveness. Whether or not this should be done in entire populations or in selected populations, or whether or not we should still focus, certainly, particularly in low middle income countries, on primary immunization before we even move on into booster vaccinations, is a very difficult discussion, important discussion to continue. With that, I thank you and hand back over to you, Mrna.
Thank you very much for a wonderful talk. We do have a few questions in the chat, and I think because we're right on time, we can go ahead and ask those questions now. So I'll ask these questions to you from the chat. The first is from Dr. Clarence Seacrest, and it's, is there now data for heterologous priming between Pfizer and Moderna? For instance, the first dose is Pfizer, the second dose Moderna, or vice versa. And then the follow-up is, and heterologous boosting with mRNA vaccines, i.e. boost with Pfizer, those primed with Moderna, or vice versa. Do you have any data on that? Have you seen any data on that?
So there is data coming up from the COMCOF study in the UK. I don't remember if there was an advantage whether or not you give Pfizer or BioNTech first. Sometimes I consider BioNTech as a fractional dose of the Mrna vaccine, and that is something that is probably that we will see those data being published soon. And the second combination, I'm not sure what, I forgot the second.
I think the second one is if one has gotten 2 doses in the primary series with either Moderna or Pfizer, and then you give the 3rd dose with the other. I think that's the question, Claire. And if you want to clarify, if I'm not interpreting that correctly.
No, that's correct. Thank you. I was impressed by the fact that the FDA currently has only licensed 1 vaccine, and such only half of the Americans are eligible for being boosted with Pfizer, not those who were primed with Moderna. So I was wondering what the science wants behind the politics.
I had exactly that same thought when I observed the WRPAC and the ACIP recommendations later on. The NIH is doing a clinical trial now with the 3 vaccines used and the 1 vaccine licensed in the US, Pfizer, Moderna, and J&J, and they boost 6 months later, at least 6 months later, I think, 50 subjects per group with the other vaccines, which they haven't received for primarization. So these data, I think, will be published rather shortly. I haven't seen them yet, but and there's similar data coming, obviously, from the UK task force. As far as I understand, yes, you can combine mRNA and do it this way or the other way around. The difference we may see is there might be a difference. These are different doses. Whether or not this translates into clinical relevance, I think if you put all Moderna trials and all Pfizer trials next to each other, you do see a consistent trend towards a higher immunogenicity of the Moderna vaccine as compared to the Pfizer vaccine, which isn't so surprising. It's 3 times the RNA dose. You also see consistently, I think, higher reactogenicity and maybe even a higher rate of, for example, myocarditis post-vaccinations in younger age groups. So difficult to comment. I'm not sure if I think it is interchangeable. I think it doesn't really make a difference. The question really is, how much antibody do you actually need to be protected for a long time? I'm sure that Stanley will tell us more about that.
Thank you very much. And I do know the original ACIP guidelines were if you didn't know whether you got Moderna or Pfizer, you don't have documentation, you can go ahead and give the other if one wasn't available. But I will say it has caused some consternation here in terms of what Moderna and J&J recipients, whether or not when and how they'll get a boost. We have another question from Mohammed Yousafzai. I'm sorry if I've mispronounced your name. The question or the comment is, intradermal route could be the possible solution for very minute doses. There are needle-free intradermal devices available, which could be used for the administration of fractional doses. And I was very interested in the studies that CEPI was doing, and I'm wondering if CEPI is looking at this and using novel delivery techniques as well.
Yeah, good point. Thank you for that question. In principle, these are very interesting concepts. We are encouraging, we are CEPI, the I standing for innovations, and we are happy to look into this. There is some challenges still. For example, are we on safe grounds to state that the immune response observed via intradermal immunization is comparable? You still see that there's a lot of discussions even for neutralizing, intramuscularly injected vaccines, neutralizing antibody titers. Do they actually correlate well enough with vaccine efficacy that regulators allow immunobridging for regulatory trials? Although I think we are, for the very first time, in a situation where we have tested so many different vaccine platform technologies. We've never done that even for influenza. I think the evidence pointing at an immune correlation is much better for coronaviruses than it has ever been for influenza and the 1/40 titer. How this translates into alternative application routes, not just intradermally, but also intranasal, for example, mucosal applications, is one aspect that has to be considered. The second point I'd like to make is, yes, there is these intradermal application devices. And yes, we have experience with strictly intradermal application, even in low middle income countries. I mean, some of the vaccines, there is dose sparing strategies for the rabies vaccines. It has been used for yellow fever vaccine campaigns and outbreak situations. It's not that easy. It's not that easy to strictly inject intradermally. What can go wrong will go wrong, not just in low middle income countries, certainly also in my home country in Germany, they will screw that up. And these intradermal application devices, yes, they are out there, and yes, CEPI might be interested in these innovation techniques, but CEPI/COVAX is also interested in providing large quantities of vaccines out to the world. And whether or not these application devices are then, if you have to balance antigen saving strategies with challenges, rolling out not just the vaccine itself, but also the device, is something that has to be looked at.
Agreed. We have a few more questions. Are there additional non-clinical studies needed to support booster doses and fractional doses?
Yeah, I think we do need studies. I mean, there is a lot of studies underway, as I mentioned, in the US on booster studies. There's the, as I said, Cough Boost program in the UK, which is testing vaccines used and not yet used in the UK as an additional dose given for booster. And some of these vaccines are being tested as fractional doses. So there is studies, but we also need studies that test fractional doses for vaccines not used in high-income countries, that are generating evidence, in particular for those vaccines used in low and middle income countries. And we in CEPI, but also with others, with the Gates Foundation, for example, with COVAX, with the clinical development SWAT team, we try to help studies to start and support these studies to be undertaken as quickly as possible. That's why we have this platform. So we hope to be able to release that call, I think this week, hopefully, for this platform approach for booster fractional doses.
Wonderful. And then a couple questions on breakthrough infections. The first is, would you have data about the extent of breakthrough infections among healthcare workers and the percentage of breakthrough infections among those vaccinated with inactivated COVID vaccine?
Sorry, can you read, what was the question?
So it's a two-part question. One, do we have any data on the extent of breakthrough infections in healthcare workers? And the second part of that is the percentage of breakthrough infections among those vaccinated with inactivated COVID vaccines. I can just comment on my experience at Hopkins, and that's most of the healthcare worker infections actually occur outside of the healthcare setting. They actually occur while they're going about their normal business. But if you have comments on breakthrough infections in healthcare workers and then breakthrough infections by vaccine platform, for instance, inactivated vaccines.
Yeah, I'm probably not the best person to answer this as a clinician. I think that the epidemiologic data are still incomplete. From my perspective, it's not that straightforward. Again, I mentioned initially, it is, I think, important to separate between infection transmission and disease. And it's even getting more complicated in the context of variants. So breakthrough infections being, PCR positivity, for example, is one aspect. Does that person get ill? Is another question. Even for PCR positivity, does that mean this is a viable virus that can be transmitted further? So even an infection does not mean that this is still a transmission, or that this person is still able to transmit this vaccine further. So I think it's very difficult to just put these numbers out there. And I think this also holds true for herd immunity thresholds for a vaccine which does not provide a sterile immunity. Yes, I've seen these data from the whole variant inactivated vaccines out of China. Again, you have to separate between clinical endpoints, severe disease, and infection. Yes, we may see more and more breakthrough cases, infections over time, but even those vaccines seem to maintain a very high vaccine effectiveness against severe disease endpoints. And we also see reduced antibody titers in the mRNA vaccines. So I think it is a little bit too early, to state, in the long term, what we really need, what is the best immune response, what is the best vaccination combination or schedule or strategy out there, before we are even able to answer questions on when and with what we should boost.
Thank you. And the next comment, I'm going to sort of summarize the comment because we've seen this, I've seen this at Hopkins as well in returning students from international locations. Some of the groups who have received different types of vaccines may not be considered fully vaccinated for travel and other places. For instance, at Hopkins, they are accepting only FDA-approved vaccines as fully vaccinated. So people coming internationally who may have received WHO authorized vaccines, but vaccines which are not FDA approved are being required to be essentially revaccinated. And the question is, what can we do to move the needle on this? And I think it's a very important question. I will tell you, I lobbied extensively against that policy and to accept all vaccines. But I'd be interested in your perspective because I think this is something that we really need to address.
I completely share this, and I like to add one aspect. In my last slide, I showed that the world is moving to a seropositive world through natural infection or vaccination. And if you have been infected naturally, should you still get 2 doses or a single dose? That is something we don't know yet. The recommendations are, as you described them, Mrna, even in Europe, you can only go into a restaurant or cross European borders if you have vaccinated twice, fully, with the vaccines out there. Does that make sense? Are we not putting people at increased risk potentially for, I don't know, signals? Vaccinated millions of people who had been infected before without recognizing it. I think we would have seen a signal if there was a signal with giving 2 vaccines post-natural infection. But I do see that these recommendations, I have been speaking with so many persons around me, my physicians that have been infected naturally and then had to go through 2 vaccinations again. Which vaccine should be given? I think this will be overcome, as soon as we progress with vaccination coverage. And then I think, we can lift these. But so far, I think we have to cope with some of these recommendations which we struggle with.
Yes, thank you. And I think that addressed actually the last comment, which is, are we riding the wrong horse to propagate booster in wild type infected populations? For example, with 84% seropositivity. So I think your last comment very much addressed that. And I want to thank you for a wonderful talk and thank everyone for the questions. This was really interesting. And we're now going to move to Dr. Plotkin. If we can bring up Dr. Plotkin's slides, that would be great.
Anna, I just sent you.
We've got them up now. So I think if you can get started, and it's really my great pleasure to introduce someone I think everybody who's been to ADVAC knows Dr. Plotkin, but I'm very pleased to present his talk or have him speak on the 3rd doses for COVID vaccines. Thank you so much, Stanley, and I look forward to your talk.
Okay, let's see now. How do I move them?
I think you can either ask the AV person to forward them.
All right. Well, so the first thing I want to say is that I agree with everything that Jakob said. And of course, he has terrific slides. And probably the best thing I could do is just shut up. But nevertheless, I'll try to add something. If I could we move the slides? The first slides really don't warrant showing again. If we could go to slide 12, can you do that? I don't think we need to talk much about principles of, yeah, okay, thank you. That's great. So as I just said, what I'm going to say is really complementary to what Jakob has so clearly said. And I certainly can't improve on his presentation. But just to make a few points, one concerns the correlates of protection. Now, I'm not going to go into a lot of basic talk about correlates, but of course, now that we have great knowledge about the immune system and its redundancy, and the fact that there are numerous types of antibody responses, that there are numerous types of cellular responses. And when we try to identify what is the correlate of protection, what we're really focusing on is what is the most important immune response, not that other immune responses have no importance, but in order to make decisions about vaccination, we need a correlate that is useful in that regard. And it turns out that, in fact, the correlate of protection for or against SARS-2 is clearly antibody. Now, having said that, again, I want to emphasize that our neutralization tests are artificial in the sense that we take a certain amount of virus and we incubate it with a certain amount of serum and we try to get an answer. That has probably not much to do with the biological situation. But at any rate, it is important to note that neutralization is a function that is induced by our COVID-19 vaccines, and that therefore this is an important biological fact that we can use to make decisions about vaccines, that is, whether a vaccine is useful or not. So what this slide shows is comparison of a number of different vaccines against using convalescent serum as a way of a method of comparison. In other words, the responses to each vaccine compared to the responses of individuals who have been infected, and also comparing that with the efficacy, the clinical efficacy of the vaccine. And so what you see on this slide is that for the mRNA vaccines and also for the Novavax, a nanoparticle vaccine, that the titers are considerably higher than the titers of convalescent individuals. Whereas for the AstraZeneca and the inactivated vaccines from China, the responses are relatively lower. And I think I could say that in terms of neutralization ability, that a titer of 500 or more is likely to bring high efficacy, whereas lower titers will have lower efficacy. And indeed, titers under 100 are vaccines that do that are going to have relatively low efficacy. And I believe this has been shown with, in addition to these vaccines, with other proposed vaccines that have been tested in clinical trials. So the next slide. And this is another way of showing the data, perhaps more graphically. And you can see again that on the left part of the slide, the vaccines, the mRNA vaccines are shown, Novavax in the center, and the adenovirus vaccines on the right. And again, you can see in this case, comparing the Wuhan antibodies against the Wuhan strain with antibodies against the Alpha variant, you can see that there are similarities and differences between the two variants, but basically neutralizing antibodies reflects the efficacy of the various vaccines. Next slide. Next. Yeah. And a number of workers, particularly an Australian group under Miles Davenport and a British and American group under David Goldblatt, and the Oxford group under Mrna Voisey, have all shown really more or less the same thing, that if you look at the x-axis, the measure of antibody, and the y-axis, the measure of efficacy, that there is a very good relationship between the two. Next slide. And this is an example of the reduction of antibody after the Pfizer mRNA vaccine to the point where the responses on the right part of the slide, you can see are comparable to those after in convalescent patients, which also means that the efficacy has dropped as well as the titer. And so we're then talking about a less efficacious vaccine response. Next slide. Here, this shows that there is a correlation with age, in that the responses, in this case, against the receptor binding domain, this is 1 week after the second dose. You can see there are lower responses in the elderly, not surprisingly. And the next slide shows the results 6 months later. And you can see that the titers, the y-axis is a much lower number, and that again, the elderly have lower titers. And so this indicates that the protection afforded by the vaccine is going to be lower. Now, here I want to make what I regard as a very important point. And that is that if you look at any inactivated virus vaccine, or for that matter, bacterial vaccine, that the interval between doses is critical, that all of our inactivated vaccines require a dose 4 to 6 months after the first dose in order to give the maximum protection. And therefore, from my point of view, it was always going to be necessary to have a second or third dose of vaccine in order to achieve the highest and the longest lasting responses. I realize that is a somewhat controversial statement, but is one that I strongly believe in. The next slide. I think the next. Well, so this is a slide which I believe Jakob has already shown. This relates to the chimp adenovirus vaccine, showing the responses after the first dose, the second dose, and the third dose. And again, I want to point out that the higher the titer, and here we're getting up into the 5,000 or so, the more likely the efficacy is going to be high. And let's move to the next slide. This is also a point that Jakob has made well, and that is that the broadening of immunity that occurs after the third dose means that we will have better protection against variants. So at the maturation of the immune response after the third dose, shown here for the alpha, the beta, and the delta variants, means that we will have better protection against the variants that are circulating, and hopefully against any new variants that will crop up. So this is another very important point with regard to the third dose and the maturation of the immune responses. And the next slide. Well, I don't think I need to tarry on this, except that this is again the chimp adenovirus, and let's skip this slide and move on. Next slide. Yes. This again is the chimp adenovirus, and this makes a point which is related to what I've just said, but it illustrates that the interval between doses for the chimp adenovirus vaccine, which had only a moderate efficacy when doses were given at a 4 or 6 week interval, you see that extending the interval to 12 weeks improves the efficacy. And that's because the immune responses are higher with a longer interval, which allows maturation of the B cell responses. Next slide. I don't think I need to repeat what I've said. These are figures including some other vaccines and different intervals, but again, the higher the titer, the higher the efficacy. Next slide. And again, the same point. I won't be redundant. Next slide. So what about T cell responses? Probably the best thing to say about the importance of T cell responses is we have no real idea. The data are not convincing. However, obviously, in order to have an antibody response, one needs a CD4 T cell response. There are other functions, of course, of CD4 T cells besides their impact on B cell production, but nevertheless, the point here is that the vaccines that we use do induce CD4 T cell responses, and whether they are important in themselves or not remains to be seen. And the next slide illustrates that these responses are not terribly high. And when you then discuss CD8 T cell responses, which some workers feel is important to efficacy, they are relatively low. So I would say that the evidence for their importance is low. Next slide. But this does make the point that there are CD8 T cell responses to infection with the virus, and that most of these responses relate to the nuclear protein, which is not present in many of our vaccines that depend on the spike protein. So that may be an interesting point for the future development of SARS-2 vaccines. Next slide. Well, I've already made this point about the importance of the interval. The longer the interval, the higher the immune response is going to be. Next slide. So I will conclude with some known unknowns. And the first is I've already pointed out the importance of T-cell responses remains controversial. There are vaccines that only use the receptor binding domain. And there is a question about whether that is sufficient, because there are epitopes, other epitopes on the spike protein that seem to induce responses detectable by ELISA and to some extent by neutralization, and they may be important as well. A duration of antibody responses. I think it is likely that third doses will improve the duration, but we need evidence for that. And then we know little about mucosal responses. Unfortunately, they have seldom been measured in the studies that measure efficacy. Undoubtedly, they are important, if only to prevent replication in the mucosa and the possibility of infecting other people even from vaccinees. But we need a lot more data on that. Next slide. I think we know that the elderly respond poorly, which is another argument for using third doses in the elderly, as has been decided in the United States. Will vector immunity become a problem? This is, I think, particularly important for the adenovirus vaccines. Will we be able to use additional doses? The data so far on third doses appears to be good, but we'll need to follow this issue as well. Will decline in immunity lead to frequent infections? Yes, there's, I think, no doubt about that. Will COVID-19 become endemic? We don't know, but I think it is fairly likely that it will. And will SARS-2 continue to mutate? I think also that is likely, but so far the mutations have not totally escaped our ability to control them with vaccination. So in summary, everything that, as I said, I agree with everything that Jakob said. What we need in the future is to follow the immunity after third doses or second doses in the case of the Johnson & Johnson vaccine, which also has shown a great immune response after that second dose and broadening of the immune response. So we need to follow the individuals who have had the third doses to see whether they will need additional doses in the future or whether their antibodies will plateau and effectiveness will continue. And I will stop there. Thank you.
Thank you so much. Please feel free to write your questions into the chat and we'll get to them. I have a couple of questions while we wait for others. My first question, and you touched on it a little bit, in the early studies of the AstraZeneca vaccine, as you pointed out, there was difference in efficacy if the vaccine, the two doses were given 1 month apart versus 2 months apart. And some questions that arose at the time around that were, is there antibody to the vector that's limiting the immune response when we give the second dose at 1 month versus 2 doses? I have not seen any data on measurement of titers to the vector post any of the doses of vaccine. And I was just curious whether or not you have seen any data on that or not.
I've seen fragmentary data, and the second dose does increase the adenovirus antibody response, but it doesn't, it certainly doesn't seem to interfere with the immune responses to the insert. And I think that's at least in part because these are not replicating vectors. If we were using a replicating vector, I think that would be more of a problem. But for these non-replicating adenovirus vectors, I don't think that's going to be an issue.
Great, thank you. The first question we have is, first of all, thank you very much for your talk. It was a wonderful talk. You said that protection against COVID-19 is provided by the specific antibodies. Are the reported antibody titers also considered protective in patients with artificial B-cell suppression? That is, patients treated with ocrelizumab or rituximab. Would these patients have to be boosted again during the therapy breaks, also more than just the third dose?
So I will adopt a, what shall I say, an attitude, even though I don't have data. But I think what I've been trying to argue is that antibodies are it. And so if an immunosuppressed individual does not have his or her own antibodies, obviously, and receives antibodies artificially, those antibodies are going to wane. So at some point, that individual, if capable of responding to an immunologic stimulus, is going to need immunization or continue with passive antibody. There's no way out. There's not going to be protection if there are no antibodies. That is the argument that I would make. Now, the counter argument is, well, you know, what about the vaccines that are not producing high antibody but are giving some efficacy? But those vaccines are not inducing no antibodies. They're just inducing low levels, and the low levels are still giving some protection, maybe 40–50% protection. We've seen this with experimental vaccines that have not been licensed. But unless they're going to be boosted, which is possible, I mean, to boost the vaccines that are not highly immunogenic, but to come along with a third dose later on, we've already seen this with non-licensed vaccines, that the third dose corrects their inability to produce high levels of antibody with the first two doses. So for immunosuppressed individuals, we have to provide antibody one way or the other, either passively or by repeated doses to stimulate a weak immune system.
Great. We have several questions now on mucosal immunity. So I'm going to go through these and see if you can just provide a general conversation around mucosal immunity. So the first is, are there ongoing studies on mucosal immunity to SARS-CoV-2? And I would expand that to say versus natural infection versus mucosal immunity in vaccination. And two, at least one intranasal vaccine is already in phase 3 clinical trial. Would it give better results than intramuscular vaccines in terms of efficacy or effectiveness is the second question. And the third question is, will there be any room for an intranasal vaccine after immunization with any of the authorized COVID vaccines?
Well, I am a consultant to one of the companies that is developing an intranasal vaccine, and in principle, I am enthusiastic. But of course, the question is how much antibody can be induced by intranasal immunization. And the second question, well, I would say that the data show that you can induce antibody with intranasal immunization, but the key question is how long are those antibodies going to last? Because if they are temporary, then the individual is maybe going to have some protection by a memory response, but I doubt that that protection will be very good unless there is constant production of mucosal antibody. So it remains to be seen. I would hope that antibodies stimulated mucosally will last, but I am afraid, based on what we know about other pathogens and induction of mucosal antibody, that unless there is a lot of replication in the mucosa, those antibodies may not last very long. And what was the other question?
The third question is, if we do get, and do you think that there's room for an intranasal vaccine after immunization with any of the currently authorized vaccine?
Yeah, in principle, yes, because they could boost not only intranasal mucosal responses, but general responses as well. So I'm, enthusiastic about intranasal vaccines, but of course, they have to be shown to induce not only a primary response, but a prolonged response. And with regard to using them as boosters, yes, I would be enthusiastic about that in principle. If they will eliminate the need for continued intramuscular injections, you could imagine, particularly in developing countries, that it would be great to have an intranasal vaccine that you could use as a booster, if not as a primary immunization.
Great. As I wait see if anyone else has any additional questions, I do have a question, particularly, and I think this goes back to Jakob's talk a little bit earlier when we're looking at protection or efficacy against infection versus disease. We saw very, I want to sort of say discordant results from South Africa with the beta variant in the J&J vaccine, which had very low efficacy against infection, but extremely high efficacy against hospitalization, severe disease, and death. And I do wonder if there isn't roles, as we've seen historically with influenza, the role of the cellular immune response to clear virus after infection occurs, and why we're seeing this disconnect, even today with mRNA vaccines, as antibody titers go down. It's not unexpected you would see increased infection, particularly through the mucosa, but this continued high effectiveness against disease, and sort of what are the mechanisms around that?
Yeah, I think you're making a good point. And so what I will say is a guess, but my view would be that antibody prevents infection, but cellular responses control infection if they occur. So if an individual who has been immunized is infected, even with a low dose, and that individual is not likely to develop serious or fatal disease, but nevertheless, the virus is going to multiply. And what is going to control that multiplication? T cell responses are certainly going to contribute importantly to control of the replication. So when I expressed some doubt about the value of T cells, I meant that as primarily as prevention of their role in prevention of infection. But once infection occurs, yes, T cell responses clearly are important in controlling the amount of replication. And so I didn't mean to say that T cell responses have no importance at all, but as a correlate of protection against infection, I think they are lacking.
I agree with you. I mean, I think we've seen consistently that antibody titers are an excellent correlate for prevention of infection. And Jakob made a very good point about discussing what the regulatory pathway would even be for intranasal vaccines. And I don't know, Jakob, if you want to comment on that.
I would actually like to use the opportunity to ask Stanley if, it is difficult, obviously, for the mucosal vaccines. They, as you say, may have an effect rather in the upper respiratory tract against maybe infection, potentially against transmission. But at times where it becomes increasingly difficult to run placebo-controlled clinical trials, which is still possible, but these intranasal vaccines will also not be suitable for, immunobridging studies. You know the discussion, which is difficult enough at the moment. So for you as an expert in that field as well, what about human challenge studies? And maybe others on the call, is that something that is going to be, finding another or a role moving forward for those intranasal formulations?
Absolutely. As of course, we've had lots of discussions about this, and it's still a controversial subject, but I still argue for the value of human challenge studies in this regard. And I totally agree with you that that would be a great way of testing the intranasal vaccines.
Yeah, I also wonder, as we're talking about third doses, booster doses, and even doing a clinical trial where you look at you compare a third dose with an intranasal vaccine versus either no third dose or a third dose with an IM vaccine, and see if you get reductions in infection and transmission, and if so, what the durability of that would be. But then, of course, to your point, Jakob and Stanley, that limits what you're authorized to use that intranasal vaccine for. So that's a really good point.
Could I make a general statement? And that is that, of course, we all mourn the dead and the injured from this epidemic. But we have never learned more about vaccination than in the last couple of years. Many of the questions that have come up here are very valid questions that we have never been able to answer before. And now we are beginning to get answers. So this epidemic has had at least one positive value, and that is that we will know much more about vaccination after this epidemic, this pandemic, than we did before.
Absolutely. And I think to that point as well, and I think this is going to be the topic of an upcoming ADVAC webinar, but also, and this to a great extent is due to the work by CEPI and others, but the new technologies of vaccines that were used during the pandemic and the success of those vaccines, and then translating that technology to vaccines for other pathogens. I think it's really opening up and the potential for better vaccines, particularly either a universal influenza vaccine or an influenza vaccine that actually is highly effective, more so than 50% would be very worthwhile. But I think, to your point, Stanley, much as sad to say, much as HIV helped us learn about T-cell immunity and other things, I think we've learned a tremendous amount about natural infection and vaccine-induced protection during the pandemic. There's one more comment in the chat that says, we get quite technical now, but we should look much more on population immunity to break the pandemic and let the virus go into endemicity in peace. That would be, if it could be just, if with population immunity, we could get to the point where it's a common cold virus, I think we would all breathe a sigh of relief. But I want to thank you both so much. This was such a wonderful session, and I learned so much. I think everybody who attended learned so much. It was a great discussion. I want to thank you again for your time, and thank everyone for attending. And have a wonderful day. Thanks again.
Thank you.
Thank you, Anna. Thank you, Stanley, everyone.
Bye-bye.